Okay, good morning, everyone. Please take a seat. My name is Dr. James Robinsky. I'm the director of the Dahdaleh Institute for Global Health Research here at York University. And I'm absolutely delighted to host this fifth summer school Global Health Internship Symposium. We are featuring our exceptional students, and they're going to be showcasing their contributions to global health research that's taking place here at York. And I'm delighted that the symposium is taking place, and I very much hope that today we'll celebrate their journey, their work, and their progress as the next generation of global health researchers and leaders. And I'm also very happy to welcome some family members of some of the students that are here, as well as distinguished Professor Emeritus Harvey Skinner, right here, who was the founding dean, in fact, here at of Faculty of Health here at York, and is one of our most valuable members of the Dahdaleh Institute in terms of supporting students and research. And there you are. I'm literally jet lagged right now, so you'll have to tolerate, my kind of staccato sort of thoughts. I'm very jet lagged, and just back from Malawi, actually, where we were finishing up the major research program on modeling, using agent-based modeling, system dynamics modeling, and artificial intelligence modeling the health impacts of climate change in the Chilwa Basin of Malawi. It was very successful, but I am tired, so I do apologize in advance. But let me, before we begin formally the seminar, I'd like to just offer a land acknowledgement. And this is a virtual event. There's several people online, in fact, quite a few online. And I would encourage all people just to take a moment to acknowledge the territory, the traditional indigenous territories that they are on. And give thanks and gratitude and respect to the land that you're currently living on and working on. And we are here today at York University campus in Toronto. And York is situated on the traditional territorial area known as Takaranto. And we acknowledge its current treaty holders, who are the Mississaugas of the Credit First Nation. And we also acknowledge this as the traditional territory of many indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. And the territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and care for the Great Lakes region. So today, with that acknowledgement, I'm delighted that we're hosting this symposium on this territory. And the symposium is part of the Institute's Global Health Internship Program, and students apply critical research skills and pursue meaningful research opportunities under the guidance of leading global health researchers here at the university. And the Dahdaleh Institute we use what we call a critical problem-solving approach to pursue effectiveness, equity, and excellence in global health research, policy, and practice. And just in a nutshell, the idea of effectiveness is that whatever it is that we seek to do, it has to work. It has to be effective. And then the concept or the principle of equity is that we really do focus on the most vulnerable people in our human societies. And the reason for that is if we focus on the most vulnerable, there will be benefit to all. But if we only focus on the most privileged and the most rich and the most elite and so on, eventually, maybe sometime in the long distant future, there may be some benefit to others. But by focusing on the most vulnerable and seeking equity among all people, we actually benefit all people. So that's why we do that. And then the other core principle is excellence. There's no double standards. There's nothing for the North, the global North. There's no difference in how we approach issues in the global North or issues in the global South. There's no difference in terms of how we approach issues for rich people, for poor people, for Black people, for white people, for all sorts of people. Excellence is our standard. That is it, right? So it's effectiveness, equity, and excellence. And that's how we approach our critical problem solving around global health research, policy, and practice. And it's very clear that our students, and particularly our interns, have really absorbed that and have absorbed it into their way of seeing the world and their way of behaving and approaching research. And I'm very, very proud of the accomplishments that the students have achieved over the last year. And the program that you're part of, it uses what we call experiential education to provide opportunities for students to work with faculty and fellows through living experience and guidance and mentorship. And all of you as students have had that experience. It has not been a textbook experience. It's been a very real hands-on research learning opportunity. And I'm delighted with what you guys have produced. And we operate within the Institute around three themes. One is planetary health. The second is global health and humanitarianism. And then the third is global health foresighting. And just for our guests, I'll just give you a brief description of each one. Planetary health is really about the relationship between human civilization and our biosphere, and how human civilizations and the activities of human civilizations affect the biosphere, and then how that subsequently affects us. Global health and humanitarianism really focuses on providing new tools for better policy and practice around clinical public health priorities for some of the most vulnerable people in the world. And these are refugees and internally displaced people and people in situations of social uncertainty is probably a nice general way of describing non-conflict situations. So there, for example, we've developed a whole series of safe water optimization tools that reduce the morbidity and mortality secondary to infectious diseases or waterborne infectious diseases in refugee camps and IDP settings. And we have a number of other projects, but that's just one example. We also have a policy working group on humanitarianism and what that is, and what it is argued to be in the past and the present, and hopefully for the future. Under global health and global health foresighting, we have a whole bunch of projects, but one that I'll tell you about, its use of artificial intelligence and machine learning to understand clinical public health priorities in different parts of the world, different regions of the world. And this is a very, very successful already research program, and will be continuing for at least another 7 years at the Institute. So there are about 34 different research projects taking place at the Institute, all under different faculty members and different faculty teams. And the students, the interns, have been part of that network of research and have, through experiential learning, have gained some really, really important critical skills for global health research. So that's just an overview of what we do at the Institute for our guests and also for our students, so you know what the takeaway messages are as you move into the next phase of your career. So today at the symposium, it's really a showcase of this year's cohort of students. And each intern is going to describe what they did and what they learned and the major tasks that they carried out. They'll also share how their work has contributed toward research addressing the particular global health challenge that they've taken on, or that the team that they've joined has taken on. And some of the topics that will be discussed are experiential-based simulation learning, effects of resource insecurity on health outcomes, mental and emotional health and wellness, post-pandemic public health reforms, and impact of human behavior on antimicrobial drug resistance. And we hope the presentations that we'll see today can also inspire other students and faculty to participate in the Dahdaleh Institute's Global Health Internship Program. And so for prospective interns, you can find upcoming opportunities, and these are posted on our website under the internship program page. And you can also sign up to our newsletter. And specifically, we're still recruiting for 2 more positions. One position is on is to assist as an intern on the impact of human behavior on antimicrobial drug resistance. The deadline for that position is tomorrow. And then another position is development of photocatalytic nanomaterials for wastewater treatment. And that deadline is September 8th. So this is roughly a 2-hour event. And we're going to start with the first 4 presentations, and we'll have a brief question and answer and discussion session. And this will be followed by a very brief break for some muffins and some water. And we're going to resume around at 11 with the remaining 4 presentations. And we'll conclude with another round of questions and answer and discussion. And we will wrap up sharply at 12. So I just remind those online to use the chat box feature, and also to use the raise your hand feature in the Zoom software. And please note that we are taking comments and questions. We will be taking comments and questions at the end of presentations. So let's start with the first 4 presentations, and then we'll take questions at the end. So let me introduce, our first presenter, and that is Stephanie Hychar. And Stephanie is working with Professor Shital Desai in the Department of Design. And Stephanie is working with Professor Desai using design research methods to collect data on antimicrobial resistance. And the title of her presentation, Stephanie, where are you? Oh, perfect. Why don't you come on up as we're getting you ready. The title of her presentation is The Impact of Human Behavior on Antimicrobial Resistance. And before I give you the podium, I'm just going to ask Laura Logan to ready herself, because you'll be next, and then I'll introduce you after Stephanie. So Stephanie, welcome. And here you go.
Thank you for the introduction. I wanted to first take a moment to thank the Dahdaleh Institute, the symposium organizers, and my supervisor, Professor Shital Desai, for the opportunity to present today and to be a part of this project. Since June, I've been working with a research assistant under the supervision of Professor Desai here within the Social and Technological Systems Lab at York University and the Institute. Our area of research has been on antimicrobial resistance, or AMR, and human behavior. So antimicrobial resistance occurs as microorganisms adapt and become insusceptible to the substances we have created to destroy them. This can be seen specifically with infections becoming more and more resistant to antibiotic treatment. This is a major global health issue because it's affecting populations worldwide, and there are complex interactions between the environment, human and animal health that are driving this problem internationally. The goal of our research is to investigate human behaviors that are impacting the spread of AMR from a design perspective. Current behavior research focuses primarily on antibiotic use, how consumers are using antibiotics, prescribing behavior from healthcare professionals, and how it's used in agriculture. So this study will go beyond antibiotic use to address the other established drivers of AMR, such as environmental contamination, excuse me, sanitation and hygiene, healthcare transmission, suboptimal vaccination, and travel, all through examining human behavior. I contributed to this project by conducting a literature review on current research on human behaviors that are impacting AMR and developing survey questions informed by the research, as well as designing recruitment materials for the study. I learned a lot about the work that is involved in preparation for conducting a research study involving humans, all the different aspects that need to be considered in starting from planning, how to get consent, the research methodology, and all the way to designing recruitment materials in order to get the study off the ground. I was also able to practice efficient desk research skills through conducting a literature review on the current research surrounding human behavior and its impact on AMR. I conducted the literature review through keyword searches in several databases and by using the snowball search method to collect relevant research and to identify research gaps. I learned specifically how the drivers of AMR differ drastically between lower income and higher income countries, and a greater focus on researching the behaviors driving AMR transmission and dissemination is needed. For example, more research into the role sanitation, infection control, and hygiene is playing in spreading AMR is needed, especially in lower and middle income countries. The problem of AMR is complex and systemic. Innovative solutions to address it require interdisciplinary collaboration, which is the cornerstone of the One Health approach. So I learned specifically how design research can be used to address AMR. Surveys and interviews will focus on empathizing and understanding human behaviors, and this will then lead to defining the specific problems that we can address to create behavior change. And then finally, co-design workshops can be used to ideate solutions directly with stakeholders. And these are the next steps for this project and this study going into the future. Now that the summer has come to a close, I'll be returning to the Bachelor of Design program this September to complete my third year as a full-time student. I plan to continue specializing in interaction design, and I'm actively seeking a UX design internship for summer 2024 to fulfill my degree requirements before graduating in 2025. I'm really passionate about research-informed design, and I aspire to find a role as a UX researcher specifically, where undoubtedly the skills I have developed here in my time on this project will help. Thank you for your time.
Thank you, Stephanie. Well, I'm sure there'll be questions after the four presentations. I will just note that this year we had a special global health design focus, and we had 6 major workshops led by world-renowned designer Bruce Mao, who worked with us at the Institute, as well as Professor Shetal Desai and Angela Norwood at the Department of Design. And it was a highly, highly successful program. And we're working on a book that will come out of that. And we are looking to incorporate design principles into our approach to global health research at the Dahdaleh Institute. I'm very happy, Stephanie, that you've really leapt in at the micro detail level, and you've obviously had a great experience. So our next presenter is Laura Logan, and Laura, where are you, Laura? Yeah, come on up. Laura is working also with Professor Shetal Desai, and she's investigating and analyzing how people respond to and manage their chronic pain. The title of her presentation today is Experiences excuse me, and Emotions of People with Chronic Pain. So with that, Laura, over to you.
Thank you.
Hello, everyone. My name is Laura Logan, and I'm a research assistant under Dahdaleh Institute's Global Health Foresighting, and my supervisors are Dr. Shetal Desai and Dr. Mark David Hosam. The project I'm presenting today is called The Emotions and Experiences of People with Chronic Pain. Chronic pain we define as a persistent pain that is lasting at least approximately 6 months. So this project aims to investigate how people with chronic pain use different methods and tools to manage their pain and any possible correlations between their experiences and their biophysical responses. And in the future, we hope to find possible patterns to help people manage and treat their chronic pain. This project study consists of an interview using a sensor in this image here called the BioPack MP40. It will collect electrocardiogram data such as the heart rate and heart rate variation. The three main tasks that I did during this research project was I was involved with the proposal application process of the research project. I managed the participant recruitment as well as contacting them, and then I conducted the research study with them. Thirdly, using the data that I collected, I'm currently analyzing it to find correlations and questions of interest of the technologies, the medications, and social connections related to a person's chronic pain. During this internship, I have learned the preparation process for formal proposal applications, as in the proper consent and ethics protocols. I've been using and improving my project management and organization skills. I've conducted independent research on the data analysis tools, such as the Nodus Observer XT, as well as the BioPack data collection sensor. I've also been applying my critical thinking and collecting and analyzing this data in order to form meaningful conclusions. The next steps of this project are to recruit more participants and continue analyzing that collected data, as well as including another layer of data analysis using a face reading tool in order to track the participants' expressions. Lastly, this internship opportunity has been very inspiring for me to continue pursuing an interest in the research of other medical fields and their technologies, since I am a digital media student and I am interested in other technologies, and it's very interesting to see different applications. I'd like to say thank you very much to the Dahdaleh Institute, the symposium organizers, as well as my supervisors for this internship opportunity, as well as this invitation to present my work. Thank you everyone for listening.
Oh, that's really, really good. Thank you.
Very much.
So that was terrific. And I know Laura only just very briefly touched on the scope of her experience. And I think what strikes me is that you know, she has really grasped the scientific method, right? That it's about defining a question, illuminating that question, creating a hypothesis, generating an appropriate methodology to test that hypothesis, and then identifying appropriate samples, subjects through an appropriate identification method, then identifying appropriate metrics for your indicators, and actually testing, gathering that data, analyzing that data, and then presenting it in a meaningful way. Now, that process is a very, very complex process. And it is a process that it's rife with all kinds of rabbit holes. You can go wrong with it, but clearly, Laura, you've really grasped it, and it's very impressive, and most especially in terms of your digital media perspective. And I would love to see where you go with that training in relation to global health research. So it was a fantastic presentation. Thank you. And our next presenter is Kanako. And Kanako, do you want to come up while I introduce you? And Kanako Isobe is working with Professor Martin Bunch, who is a professor in the Faculty of Environment and Urban Change. And she's undertaking statistical analyses of occupational health data from agricultural workers in Costa Rica. And the title of her presentation is The Mental Health of Agricultural Workers in Costa Rica. So over to you, Kanako.
Hi, my name is Kanako. I did a research project on sun heat exposure and mental health of agricultural workers in Costa Rica under supervision of Dr. Martin Bunch. I would like to thank this opportunity to present Dahdaleh Institute of Global Health Research, and also thank my supervisor, Dr. Martin Bunch, for this opportunity. So the three things that I've focused on this summer for my research is review relevant literature, data preparation, and undertake statistical analysis. This project is essentially to reanalyze the data that former master's student collected in 2020 for the research to find out association between sun and heat exposure and mental health of agricultural workers. So firstly, I started with reviewing current literature and old and current literature to find out more about working condition health of agricultural workers, as well as to understand research sites. This was done in biological corridor in Costa Rica, where York University campus is located as well, and also familiarize myself with different information about what the agricultural workers experience in that location. Also to find out new information to fill in the gap in between 2020 and now to find out more about working conditions. Secondly, I've worked on data preparation. This involved data cleaning and doing statistical analysis of the old data. I did several statistical analysis, including regression, chi-square, and correlation tests, and also transformation of numeric data using skewness and kurtosis, and to find a normal distribution of numeric data. Finally, I've uptaken statistical analysis using principal component analysis. The old research, what they're using regression and correlation, but now we finally have the complete data set. I am working on principal component analysis for this project. What I learned from this process is know more about agricultural workers, what they experience in daily basis. So before this project, I didn't know much about agricultural workers and what they have, what kind of stress they have in their life. So including like sun exposure is one thing, but they also have like long hours. They are not hydrated that often. So those things, it's very important to learn to protect vulnerable population. Secondly, I've learned to use software R to conduct statistical analysis, and also learn how to plot data, making graphs, and then plotting visuals in the process. Finally, I've learned the importance of preparation to work on the big data set. So there are a lot of missing data and duplicates of data. So I've worked on, focused on data cleaning in order to uptake statistical analysis and find more accurate results. Finally, what I plan to do is I'm planning to focus, continue working with Dr. Bunch in the fall 2023 and finishing principal components analysis, and also closely working with Dr. Douglas Galaza, who is a professor at University of Costa Rica, to finalize analysis and comparing our data with the research papers that Dr. Galaza published on agricultural workers. She touches on a lot of working condition employment and also health of agricultural workers. We will be comparing our data set and findings with those papers. And secondly, I will be entering my third year of Bachelor of Science in Global Health. I'm excited to be taking epidemiology courses and meta-analysis to deepen my understanding of research. And finally, I continue to work full-time as a program supervisor at a local community center to promote health and well-being of the community. Thank you.
That's great. Thank you, Kanako. That was great. I have lots of questions for you, but I'll hold them until after the next presentation. The next presentation, our fourth, is by Megan George. It's virtual. Megan is working with Professor Hamid Faraz Khalid and Professor Adrian Veens, and Adrian is here to answer any questions, I'm sure. Megan has been working to coordinate and conduct a mixed method study on the 2023 World Health Assembly simulation. The title of the presentation today is Contributions to the World Health Assembly Simulation and Investigating the Importance of Experiential Simulation-Based Learning. So Megan, over to you. Are you there online?
Yes, I am. Can you hear me? And
go ahead. Yeah.
Perfect.
We can hear you nicely.
Perfect. Okay. Good morning, everyone. Thank you, Dr. Rubinski, for the introduction. My name is Megan George, and I'm a research coordinator within the Faculty of Health. I apologize for not being able to be in person today, but I'm really excited to present my work today. I would like to thank the DIGHR for giving me the opportunity to present the work that I've been conducting over the past several months, as well as my amazing supervisors, Dr. Ahmed Faraz Khalid, as well as Dr. A.M. Viens, who have been super supportive and great mentors thus far. So today I would like to give you all a brief overview of the work that I've completed thus far, and the title of my presentation is Contributions to the World Health Assembly Simulation and Investigating the Importance of Simulation-Based Experiential Learning Among Global Health Undergraduate Students. So to begin, what is simulation-based experiential learning? Well, essentially, it involves supporting critical learning areas, applying theoretical knowledge into practical settings, and being able to do so in a safe and risk-free environment. Essentially, it is learning through doing. So next, I would like to highlight the 3 key initiatives that I executed at the DIGHR, as well as the School of Global Health. The first is the design and implementation of the 2023 World Health Assembly simulation, which spanned from September 2022 to May 2023. In this process, I was able to apply for multiple grants. I also reviewed the literature to determine current global health issues and policies to identify a theme that was relevant for our simulation. And through that process, I identified the theme as being building solidarity for worldwide health security. I was also able to register participants and recruit amazing guest speakers. And this event was highly successful as we convened approximately 100 students and 15 great guest speakers. In addition, I conducted a mixed methods study, and through this process, I was able to create surveys for the purposes of our quantitative approach, and I also conducted and coded interviews for the purposes of our qualitative approach. I also reviewed the literature on simulation-based experiential learning for the purposes of our manuscript writing, which is still under works. Based on the mixed methods study, our research question ultimately wanted to understand to what extent does creating simulation-based experiential learning experiences improve students' skills in analyzing complex global health problems and generating innovative solutions to those problems. And based on the several interviews that we conducted, 3 common responses were provided by students to answer this question, which were that this experience exposed them to multifaceted perspectives, provided them with collaborative synergy among their peers, and was a feedback-driven learning environment that increased their analytical abilities and ability to generate innovative solutions, which may not have necessarily been easily achieved in a classroom setting. Finally, I transitioned into a research coordinator role this past May, which has been really exciting. And through this process, I was able to facilitate weekly discussions with my PI as well as our research assistants. I also created a 32-page Dean's report for the Dean's Office, which essentially summarized and highlighted the key aspects of the 2023 WHA SIM. To highlight one figure included in the Dean's report, we found that 98% of students would attend a future WHA SIM, which shows how interested and willing students are to engage in such experiences. Because of this feedback, we are also currently working on the design and implementation of the 2024 WHA SIM, which will take place next May. Moving on, there were several lessons that I learned throughout this process, but to highlight a few, I definitely learned the implementation and analysis of mixed method studies and how qualitative and quantitative approaches can be integrated to answer a research inquiry. I also learned the importance of experiential learning development in global health, but more so across all disciplines, as I truly believe that students value being immersed in such experiences and environments where they can apply their theoretical knowledge learned in classroom settings in practical settings such as the WHA SIM. And finally, in terms of next steps, I'm so grateful to be returning as a research coordinator for the upcoming academic year. In this process, I hope to continue to work on our manuscript, design and implement the 2024 SIM, which I hope will be an even more enhanced iteration of the 2023 SIM, and also continuing to enhance my professional skills. I also will simultaneously be beginning in a few short days a master's in medical sciences at the University of Toronto, and I'm really excited to see what the next academic year will look like as I transition outside of York as a student and take on a research coordinator role for an extended period of time. And with that, I want to conclude my presentation by once again thanking the DIGHR and the symposium organizers for this amazing opportunity to showcase my work. I would also like to thank my supervisors, Dr. Ahmed Faraz Khalid, as well as Dr. Adrian Viennes, for their continued support, mentorship, and plethora of knowledge. Thank you, everyone.
Thank you, Megan. That was terrific. So we have a few minutes for questions, comments, discussion. So if anyone online would like to pose a question, Hannah, maybe you can just keep an eye on that and let me know. And anybody in the room, you're very welcome. Just raise your hand. And parents are also welcome, and as well as faculty and students. So please go ahead if you have a question. I would like to ask Laura, who presented on chronic pain and the emotions and experience of chronic pain. Where do you see your digital media skills that you're obviously developing? Where do you see them applying in the future to global health research? So,
I'll say that through my digital media course, I am a game arts student, and one thing that is very encouraged is to explore different technology use in order to control your games and such. And so using unconventional technologies in gameplay and such. And so I think that through this internship, it was very interesting to me because using an electrocardiogram, it's a different technology that I'm not used to. And I'd like to see moving forward, other medical technologies that possibly I can connect with my program work.
Yeah, and I was thinking as you were presenting that in digital media, there's all kinds of opportunities around virtual reality, for example, and simulation experiences. So we just did a virtual reality simulation of a landslide in Central Africa. And just watching people experience that, who also experienced actual landslide, it was really profound as a learning tool. And it's a tool that where you can modify the experience. So there's all kinds of great opportunities for you in global health research. And the other thing that I wanted to ask you was, do you see in digital media design, do you see a place for designing the interface, if you will, between, for example, a research or a product, a good or a service or a technology, and the user? So does that somehow resonate for you?
Yeah, of course. Because again, my personal experience is with game arts and developing games. So the user interface is a important thing in games where you want the player to be able to see the interface and be able to know what to do, and like to press on a button, for example, and see a response. So yeah.
No, that's great. I also just mentioned that we've had the opportunity, as I did earlier mention, to work with Bruce Mao, who has designed several virtual reality experiences as curriculum for medical training. And so everything from biology, basic biology, to surgery, how to actually conduct a particular surgical procedure. And so people can learn through virtual reality and also through that digital interface. And it is a game. Yeah, it's a
games as a learning experience is also like a big thing for me.
Yeah.
Because I have been very interested in medical and like the science fields growing up. So I do want to be able to incorporate that into like an art aspect and be able to like pay it forward, like using like learning tools to help people, like learning things in a fun and like very engaging way.
Well, that's great. And it's very obvious to me you've got a great future ahead of you. And, yeah, and I hope you'll come back in the fall. Okay, thanks, Megan. Oh, sorry, Laura. Stephanie, where are you, Stephanie? Come on up. You're going to have to answer. You're going to have to come up anyway. So Stephanie, if you remember, she did a presentation on antimicrobial resistance and specifically on the human behavioral impacts, impacts on profiles of antimicrobial resistance. And you talked about the importance of sanitation, infection, and hygiene as one of the major outcomes or one of the major learnings for you of the study that you're involved in. Do you want to talk a little bit about that?
Sure, yeah.
Nice and loud for the people in the room and then close to the microphone, if you don't mind.
Yeah, initially, what I found and what was kind of the setup for engaging with this material is that a lot of the research has focused on reducing antimicrobial use in first world countries. So it's really hard to get the data on lower income and middle income countries. So in first world countries, there's a plethora of research right now that's focusing on trying to change prescribing mentality for veterinarians in the agricultural industry, especially as well as just general healthcare providers. They're really focused on how can we help the everyday consumer stop demanding antimicrobials and antibiotics specifically whenever they're sick. However, if you look deeply into the research and the small amount of studies that have been done that are looking further beyond just antibiotic use, there's a very distinct difference between what's going on in lower and middle income countries, and that is a lack of sanitation and hygiene standards that are allowing a continuous cycle of illness that then antimicrobials are being left to basically support, and that is driving antimicrobial resistance. So a lot more research needs to be done in fixing that systemic issue. So that's, again, where a One Health approach is really imperative, because it is so multifaceted. It's a very large issue. It's not a simple task to address on one certain level. You need to be looking at the all the different stakeholders, all the different levels from community to policy making. And one of those things is going to be hygiene and sanitation, which is less of an issue in first world countries because of our infrastructure that we have that's just not prevalent in other countries. And it's the new research that's emerging on it is that the transmission and dissemination of antibiotic resistant genes and that bacteria is contributing a lot more, and that even just lowering in the use of antibiotics is good, but just by lowering it, it's not going to solve the issue. There's a lot of other things at play, as I mentioned. And yeah, human learning makes it a really big global health issue because of how interconnected everything is. I hope that answered your question.
It does, yeah, very good answer. And I will say that what impressed me the most about your presentation was that you started with a very specific, almost biomedical approach to understanding human behavior at the point of use of antibiotics for human beings, and also human behavior in using antibiotics in agricultural settings. So it was very specific about a particular moment in the life cycle of a particular antibiotic. But you ended not with the specific, but with a deeper appreciation of the systemic, structural, and ecological issues that are very much at play. Do you want to just talk a little bit about that?
About how I started the presentation?
Yeah, but how you went from this to that.
Well, it's really just about stepping back and looking at it, like, how do you logically address this issue? It's such a huge issue, and that's where the design thinking comes into play. And it's really just an argument of how user-centric design can aid and help with this issue, because you know, all the research studies that are published on AMR, they begin with saying this is a global health issue, this is a huge issue, and it's a One Health issue. Like, if you read the literature, like, guaranteed in the first few sentences, they're going to say this is a One Health problem. Well, how do you address a One Health problem? You need interdisciplinary input, and that means going beyond what you said, just the biomedical approach. That this is talking about drugs, this is talking about pharmaceutical use and medical use. It goes further beyond that, and then design thinking comes into play in that fashion in order to really set the stage of how you can solve that problem. You can use it as a framework to look at all the different areas where there can be ideation of different areas to solve the problem from a behavioral approach, of course. Yeah, I hope
that's great. Oh, you did great. And the one thing I would just add that while it's very important to go beyond the biomedical, that does not mean abandoning the biomedical. No. That is absolutely a key component. And we need to understand the biology of antimicrobial drug resistance, and we also need to understand and make sure, you know, that we protect those tools for human beings.
It's collaborative, for sure.
Well, yes, yes. Yeah, so I thank you for a great presentation. That was terrific. And Kanako, where are you? Come on up, just because you're going to have to answer to the microphone. So, yeah, so Kanako, if you remember, she did her work and her presentation on mental health approaches to agricultural workers in Costa Rica. And there were many things that struck me about your presentation. And one was that you actually, and professors will appreciate this, you actually went to master's degrees, existing master's degrees and PhDs, and you reviewed those theses as a source of ideas and also as a source of literature. It's often an area, a source area of knowledge that we don't take full advantage of. Master's degrees and PhD theses are available. They're freely available, and typically you can learn a great deal from reading people's masters and PhDs. What was your experience in reading the existing masters, and how did that help you formulate the research that you subsequently engaged in?
All the data set that I worked on is from master's students. So Dr. Bunch connected me with former master's students who work on the data set. But just to get a grasp of understanding like how they got the data from when we were then on site, because I wasn't actually there to collect the data. So the information about like how they plan the survey and how they did to get the information about working conditions and employment, how they did work with different professors to get information from local professor were very important to further analyze data and why the data was presented in certain ways.
Okay, that's great. And you also you made many insightful comments about data and what kind of statistical analyses are possible. So you said essentially, and correct me if I'm wrong, but you said essentially that given your existing data, you were able to do various forms of linear regression analysis on that existing data. But once you completed the data set, you were actually able to do principal component analysis, right? And I thought that was for a young third-year FE student. I thought that was just fantastic that you really not just can say that, but you actually know from your experience that the volume and the quality of the data is fundamental to the kind of analyses that you can do. So can you just talk a little bit about, I don't know much about principal component analysis. I've heard of it, but it's not an area of expertise that is something I've developed. Maybe could you talk a little bit about that? What is it?
I'm working on that right now, so I cannot talk too much
talk a little
details about it. But principal components analysis is basically instead of doing linear regression model, it goes in different, so it's 3 different dimensions. So you can discuss, you can analyze a little bit more on what variables affect in certain things in the graph. So it's more 3D image of things to look at the data instead of just linear model.
So is it a kind of a triangulation,
yes.
A correlation triangulation across dimensions? That's essentially what it is. Yeah, that's fantastic. Wow, that's great. So what are your plans after you finish here?
I would like to pursue a career in epidemiology, so I'm planning to apply masters in epidemiology.
Excellent. Where are you thinking of doing that?
McGill.
Or McGill?
Yeah. The professor is focusing on global health in EOT or McGill. So
excellent. I will point out that there's 2 kind of worlds of epidemiology. There's clinical epidemiology, population epidemiology. And clinical epidemiology was actually developed at McMaster University here in Ontario. And it's the world's leading center in clinical epidemiology. It's also, they also have a very, very, a really robust and competent faculty in population epidemiology. So you might want to think about McMaster as well. But there you are. So thank you so much, Kanako. That was great. And Megan, you're online, so you don't actually have to come up to the microphone here. I don't know how we would manage that, but anyway, I loved your presentation, and I loved seeing your progress from actually sort of planning and managing the structuring, if you will, of the simulation to actually conducting research on the simulation and then becoming a research coordinator for us and Adrian. Can you tell us a little bit about that journey and what that feels like, and what is your sense of your future?
Yeah, sure. So thank you. I think it was, for me, prior to this experience, I didn't really have much research experience. So coming into this experience, I was really ready to just learn and gain more knowledge from becoming a research assistant. And I think through that process, I really was able to learn a lot in terms of literature review, in terms of how to design and implement something as big as the WHA SIM was. And through that process, I was given the research coordinator role. I think this experience has been really just a learning experience and has taught me a lot about myself and like what I'm capable of, and also just learning through amazing mentors, like I've mentioned, with Dr. Ahmed Faraz Khalid, as well as Dr. Adrian Viennes. And so I'm really excited for the future. In terms of the future, I will be pursuing a master's in medical science at U of T. So I'm excited to kind of switch gears into more clinical research, because I think that field is just as important, and hopefully do well in that area.
That's great. So you also talked about in your study, which you're now writing up, use of mixed methods. So can you talk a little bit about how quantitative methods interact, let's say, with qualitative methods, and what is the value, the overall value of a mixed method approach from your perspective, from your experience?
Yeah, so it's still currently underway in terms of consolidating the data, but I think from my experience with quantitative, it's nice to have the numbers to look at, but when you're able to conduct qualitative interviews, you're really able to kind of interact with your participants, your research participants, and gain a better insight into your research question. I also feel like you're also able to, with your research study in terms of the qualitative aspect, you're able to really gain more insights in your research question by asking the right questions to your participants. And I think it's been very informative being able to integrate both and be able to gain more insights from the integration of both qualitative and quantitative approaches. And I think it just makes the study more stronger in terms of the results of the data.
That's great. Now the simulation, the World Health Assembly simulation itself, I participated in it, and it was really wonderful, a great experience from so many different perspectives. But what was the most common comment, feedback comment, subjective or qualitative, whatever language you want to use, that participants gave? What did people say about the symposium, about the assembly?
That's a great question. So I think through the interviews, the major feedback that I received was that there's just a lack of being able to apply theoretical knowledge that students are learning in classrooms in real world settings. And I think that for me, prior to this experience, I come from a biomedical science background. So I did have that experiential aspect in my education through laboratories and being able to apply what I've learned in classrooms in real world settings. But through this experience, interacting with students from different disciplines, from global health, I feel like a lot of students felt like they were learning concepts in classroom, of course, but things like what is a WHA? What is a WHO? How do they actually come together and make decisions for their countries? And how do they represent their countries? These were aspects that students didn't necessarily have exposure to, and being able to apply that learning in a real world setting. I also felt that students really discussed not being able to essentially have that, like I mentioned before, feedback-driven learning, where you're constantly being able to think on your feet, communicate with your peers, and learn that way, which I think is also maybe a gap in a traditional classroom setting. So I really felt that students were very interested in this type of learning and being immersed in these type of experiences. And like I mentioned, 98% of students would attend a future WHA SIM, which just goes to show that students are interested in this type of learning. And I think it should be more focused on across all disciplines, especially global health.
That's great, Megan, thank you. There's one question go ahead, Nell.
So my question is,
nice and loud, and I'll repeat it.
okay, so my question is, Thank you for the presentation. Awesome. Actually, all the presentations are amazing. Taking pointers. So my question is, you mentioned that after your statistical analysis is done, you plan on comparing this with Willis's published papers. What is the purpose for that?
I'm working with Douglas, so he has a very specific, like 3 different principles that he focuses on to working condition employment in the health. So comparing the result of how the salmon heat exposure and mental health correlates with each other, and also different variables affect to mental health. He wants to compare the statistics to see the data they collected as anything that the findings that he found in his papers can explain the
it's almost like mixed methods. So going back to explain. I just have another question.
Nice and loud, Nell, please.
What is the plan for sharing of some of this knowledge to the agricultural?
Martin, like,
the question is, what is the plan for sharing the knowledge from the study with the agricultural workers? Yeah. So maybe come up here so that people online can actually hear. Yeah.
I mean, finishing this analysis and actually going to a publisher to publish this search is one thing. From there, I'm not very familiar with the site and agricultural workers, and I'm also I don't live there, so I can't really I don't want to be like going in there and then speak from like my experience and then what I've done as a research. So that's why I think it's important to work with Douglas from University of Costa Rica and what we can do from there.
That's right. Thank you. Okay, well, I'd like to thank our first 4 presenters and ask everyone to give them a nice round of applause. And let's take a 5-minute break for some cookies and some water, and I believe there's a washroom if anyone needs it just down the hall. So we'll be back promptly at 11:10. So it's now almost 5 after. So 11:10, we'll see you back in the room. Thank you.
Hi everyone, my name is Gurher, and this summer I worked under the supervision of Dr. Amrita Daftari as an admin and research assistant for topics relating to social science and TB research. And so my tasks consisted of the following. A large component of my job was to support and expand the presence of social science and health innovation for tuberculosis, which is an academic network co-founded by Dr. Daftari. And so every quarter we release a newsletter, and this was my first time working on it. Because we were also undergoing a website relaunch, as in like a redesign, my job was to refresh the look of the newsletter as well. And so after soliciting features for the newsletter and looking into different opportunities we can feature, I also worked very hard to freshen up the appearance of our newsletter. And so we published that in July 2023. I was also lucky to assist in a master's student thesis, and she was also working under Dr. Daftari. And so we conducted a literature review relating to mental health interventions in the SAARC region, which is basically South Asian countries. And finally, again, the organization I was talking about, also known as Shift TB, our main social media presence at the moment is on Twitter. And so I really sought to expand our presence there by making captivating tweets, adding the use of images, just doing things that we hadn't really done before, and as well as working on website maintenance. And so what did I learn? I definitely got insight into how master's thesis
my work, and if I would be interested, and as I am interested in doing one at some point in the future, this is very valuable to me to actually be involved in it. I also improved my ability to think of captivating and concise language for social media. As you know, Twitter is a very concise social media, and I also use MailChimp, and I learned how to create a clean design and send out an entire email campaign to over 200 people. And finally, there's a lot of taking initiative in this job, as ShiftTB is a relatively new organization, so there's a lot of room to expand. So for example, I'm pitching that we should expand it to LinkedIn, as Twitter, or we should call it X now, is not the most stable type of social media at the moment, and I think LinkedIn would be very beneficial. And so what's next? Luckily, I was offered to continue in this rate position for the next school year, and I will be doing that. As well, I hope to pursue an independent study in a topic relating to tuberculosis social science. And finally, I will be taking a full course load, as I will be in my 4th year in the Global Health BSc program. So that's all for my presentation, and thank you so much.
So welcome back, everyone. I hope you all enjoyed the first 4 presentations. I certainly did, and we have 4 more. I'm going to just remind everybody online, you can use the raise your hand feature and also the chat box. You're very welcome to do that. We will take questions at the end of the 4 presentations. And so I'm just going to jump right in. Sepinoud Siavoshi, who's here in person. Where are you, Sepinoud? Oh,
I'm online. Yes.
Oh, you're online. Okay. Okay. Well, Sepinoud is working with Professor Mathieu Poirier, and she's supporting projects on public health policy and governance. And the title of her presentation today is Post-Pandemic Public Health Reforms. So over to you, Sepinoud.
Sure. So hi, everyone. My name is Sepinoud Siavoshi. I'm going into my final year of public administration at the School of Public Policy and Public Administration at York University this fall. This summer, I worked as a research assistant through the RAY program with the Global Strategy Lab's Public Health Institutions research stream. And I will be continuing that work in this upcoming academic session. So to begin, the main project that I worked on this summer involved developing a research project, taking a look at how public health legislation had changed post-pandemic, so post-March 2020. Looking at how the different public health acts at the federal, provincial, and territorial level had been either reformed and what those changes had been. This really came out of an idea that was passed on to me by my supervisors, Dr. Adele Casola and Patrick Fafard. Given that there is increased interest in taking a look at how governments responded to the pandemic, and really now calls for inquiries into those government responses and asking the government to take accountability for those responses. So really what we wanted to do was take a bird's eye view of public health legislation during that time and now coming out of it to see what changes had been made, if any at all. So to do this, I compared the text in public health legislation and documented any changes that I saw. Many times there weren't any changes. But at this stage, I am focusing on drafting a summary of the changes that I saw and hoping to publish or publicize this, this knowledge either through a research note or even a blog post, just anything to share with the broader community interested in knowing how public health legislation had changed. At this point, one finding that I can share is that there is definitely no one way that the provinces and territories responded to the pandemic in terms of how they treated their public health legislation. So many provinces and territories, although they made changes, they weren't sweeping or transformative by any means. And many of them were very limited in terms of how much they expand the province's emergency powers or the authorities invested in public health officials, such as the chief medical health officers or local medical health officers. And so we saw that the provinces and territories really responded in a dynamic way, and the powers that are outlined in the public health legislation really expanded and contracted and kind of moved dynamically as the pandemic progressed. However, many of these reforms that I observed did not remain part of public health legislation and were only temporary. So I'm really interested in continuing this analysis and continuing to look at what was the reason that some provinces made the changes that they made versus other provinces choosing not to do much during that transformative period with their public health legislation. Other projects that I assisted on this summer included conducting a systematic literature review as part of a CIHR project grant for our lab that is proposing to investigate the relationship between public health, institutional design, and the level of public trust in public health authorities as a result of that design and those governance structures. I also had a small part in writing a literature review evaluating the gender differences in public health leadership as part of a paper that is analyzing news coverage and media coverage on the role of the chief medical health officer at the federal level and across the country, even locally. So this summer, I learned how to summarize long and complicated academic articles in a way that conveys what is relevant to my research question and that really conveys what I want to get across. I also learned what makes an effective and comprehensive research strategy through my part in the systematic literature review. And so it was very helpful sitting down with the York librarians, learning about how to put together effective search terms and how to tackle the hundreds of databases that are available to us as researchers. In working with the post-pandemic public health reforms project, I'm learning to derive insightful themes out of what can sometimes seem like sporadic or kind of non-related data to get across a theme and findings, and really how to better organize my writing to compel readers and how to convey a story through my writing. After this, I plan to continue developing my knowledge of research methods and research design during my final year of studies, and of course with my work with GSL. I really want to, I'm going to take courses related to research methods because through this experience, I really learned how much I don't know. And so I really love the technical aspect of research, of putting together research design, and I want to get better at that. I also hope to begin my analysis of the post-pandemic public health reforms project, and also assist on projects exploring the relationship between trust in public health institutions and public health governance. This idea of public trust is something that I had explored in my undergraduate studies. And so now bringing in this public health lens to it is very interesting. So I want to keep working towards that if there are opportunities. So thank you so much for listening. That concludes my presentation. I also want to thank the Dahdaleh Institute and Teresa for inviting me, and my supervisors, Dr. Kasola and Fafard, for their continuous support this summer in my work. So thank you so much.
Thank you very much, Stefan. Lovely. I have lots of questions for you, but we'll get to them, I'm sure. Our next presenter is Shamim Samadi, and Shamim is here in person. And come on up, Shamim. Shamim is working with Professor Harvey Skinner, and she is contributing to the research and activities conducted at the Global Health Wellness Impact Lab at the Dahdaleh Institute. And the title of her presentation today is Global Health Wellness Impact Lab. Over to you.
Thank you so much, James. I wanted to take the time to thank everybody here that's joining, and also thank the Dahdaleh Institute for this opportunity to join over the summer. As well, thank you so much to Dr. Harvey Skinner and Susan Harris, who couldn't join us today, but she's here in our hearts. Thank you so much, everybody. Again, my name is Shamim Samadi. I've had the honor to work with Dr. Harvey Skinner and Susan over the past summer to establish the Wellness Impact Lab, which is new. We just started in May. So I'd like to share with you more about who we are and what we've done over the past couple of months. So firstly, I'd like to introduce you to our team. Our co-leads are Harvey Skinner and Susan Harris. And also we have a new addition to our team who is a community fellow here at the Institute. Her name is Sarah Farwadi. Sarah couldn't join us here today, but I'm sure soon you'll see more of her work at the Dahdaleh. She's a new addition. As well as myself and Cher, we've been the global health interns who've worked as research assistants for Harvey, and we've honestly learned so much. To share with you about more who we are, as you know, the Dahdaleh has 3 key themes, which is related to global health in terms of planetary health, humanitarianism, and foresighting themes. We fall under humanitarianism, and you could say that our initiatives serve as under healing others. We do this through fostering resiliency and as well as managing stress. And throughout this, our mission is basically to reduce the barriers to wellness as well as promote integrated physical, mental, emotional, and spiritual health on a local to global scale. We really believe that Angel Kyoto Williams captures the essence of our work with this quote: "Without inner change, there can be no outer change. And without collective change, no change matters." Here you can see our core values on our team, and our vision is to be a hub for global wellness, promotion, and equity. We do this through 3 key objectives on the local to global reach. Sorry, yeah, it's not working. Oh, it's working.
You got it?
Sorry. Firstly, at York University, where we, for example, hosted our Climate Cafe, which I'll tell you more about in a moment. Secondly, in the local community, which is through partnering with local organizations and networks. And lastly, through the global community, which is exchanging experiences across borders and leveraging evidence-based global wellness practices. Something that I've worked on throughout the past summer is obviously sharing with others who we are and sharing with the Dahdaleh Institute who we are. Since this is a new lab, which is through the vision of Harvey and Susan's work, I really wanted people who came onto the site to see who we are and get access to our main resources. Our biggest focus throughout the summer was climate distress to action, and we created that through our Climate Cafe. When you go on the site, you'll see different opportunities, as well as see the past work of Harvey and Susan through over the pandemic hosting stress busting sessions, which has really been impactful on people learning more about meditation and Qigong. You can also check this out on the Dahdaleh website yourselves too, and see more of what I will be talking about. An event that we hosted last week on August 24th was our Climate Cafe. So you might be wondering, what exactly is a Climate Cafe? So climate change can trigger complex feelings, and our aim is to support giving voice to these emotions and experience that we are not alone. And we also want to enable conversations about different ways to take action. So this was a space where individuals can come, it's confidential, open perspectives and opinions, and people can share what they think about the changes that need to be made related to climate change. We hosted it here at the DI, which is just across here on campus. And it was a really great opportunity where we had different students from different backgrounds join us and share not just their subconscious feelings, but how they really had world views on different topics related to such as capitalism, well-being of youth, and as well as our society's culture and how media can even impact our views of climate change. So When we were executing our climate cafe, we had 3 prompt questions. Firstly, which was, what concerns do you have about climate change? Secondly, what feelings are you noticing in yourself and in others that are close to you? And third, what actions do you think might be helpful? So I'd like you all to take a moment and think about how you would answer those questions yourselves. Pretty daunting, I would assume. We had our participants basically talk through about their emotions and what they felt about it, and we noted them down on the big post-its. Cher and I were just like scrambling to write everything down. It was just so much talking, and it was really amazing to hear everybody's thoughts and opinions on different things. And overall, we got actually really positive feedback, where 7 out of 8 people said that they would actually return to a climate cafe and recommend this to people. And 100% of our participants said that they actually had a really positive experience joining us. So I'm sure you can't quite read here, but there was a lot of different topics related to different countries not being as sustainable, learning about what the culture of sustainability is. Also, lots of people found it very puzzling how social media and different media portrays climate change, whether it's always positive. We also found it important afterwards to share resources with the participants, because this was a really great way for them to ignite their subconscious feelings out and see what action that they would like to take in the future. So we wanted to provide them with a personalized resource list of what Harvey and Susan know, since they've been involved in many different projects. We shared that resource list with them, and as well as included lots of resources related to mental health, as a big part of Susan's focus and vision for this climate cafe is making people feel safe and secure with sharing these emotions, as there can be a lot of distress with that too. Another project that I worked on with Harvey and Cher was creating a mini review manuscript on the drug abuse screening test, which he published in 1982. So the drug abuse screening test is a really widely used international instrument that has over 3,000 citations and 15 different language adaptations. It's meant for clinical screening and treatment evaluation research, consisting of a 28 self-report item list. There's also different versions such as the DAS-10 and the DAS-20, which are just using the items from the 28, but in a revised version. We went through lots of different studies to see the new recent research and innovations that have came. Lots of studies actually use the DAS and compare them to new screening tests to validate the new ones. And we've seen that not only has it been a very reliable research instrument for people, but there's so much that can go into future developments in the future regarding the research in clinical psychology. So we really aim to publish this mini review into the Addictive Behaviors Journal, which is the original journal that the DAS was published in, and as well as working on a new scoping review, since the last systematic review that we found on the DAS was published in 2007. We've been working on this with Harvey, myself, Cher, and Rica as well. So I wanted to share a few more words and say that although it's not always easy to start a new project, I've seen so much passion through Harvey and Susan themselves, and they've not only enlightened me throughout the past 4 months, but I've learned so much about taking initiative and always working hard to achieve what you really want to. And of course, when starting anything new, you're going to run into so many obstacles. So your creativity is honestly your best asset. Always facing and taking on new challenging solutions and seeing what's the best that you can create out of that. If you wanted to contact any of us, I know some people, I really enjoyed watching their presentations, and your research can honestly be on such a great scale. So if there's any room for collaboration, we're always open, and we love speaking with different organizations. You can reach us at our emails here. And yeah, thank you so much, everybody, for today.
Thank you so much.
Thank you.
Shamim, I have lots of thoughts, comments, and questions, but I'm sure we'll come to them in a few minutes. But in the meantime, I'm going to ask Mirianna George to come on up. And Mirianna is here in person. She's working with Professor Godfred Boateng, one of our newest faculty members here at York. Mirianna is conducting statistical analysis and researching resource insecurity and health outcomes in the Global South. And the title of her presentation today, is Gendered Difference in the Relationship Between Housing Insecurity and Diarrheal Disease in the Informal Settlements of Kenya. So over to you, Mirianna.
Thank you so much. So good morning, everyone. My name is Mirianna, and this summer I won an undergraduate student research award from the Canadian Institute of Health Research to complete a project with Dr. Godfrey Boateng. So I did quite a bit this summer, but the three main things I did, I completed preliminary research on housing insecurity and diarrheal infections in informal settlements. I developed a research question and hypotheses based on the research, and I learned how to use data to test these hypotheses. So I learned this summer, I learned quite a bit as well. At the beginning of summer, I took an assessment of my skills relating to evaluating scientific literature, using data and communication. And I put myself on a 2 on a scale of 1 to 5. And as of August 2023, right now, I would say I'm at a 5 in most of these categories, except for presentations, which I'm a 4. This is actually only my second presentation. So this summer, we completed a project on the gender differences in the relationship between housing insecurity and diarrheal infections in informal settlements. We chose to do this project because there are currently over 1 billion people living in informal settlements around the world. And informal settlements are characterized by various forms of resource insecurities, including housing insecurity, which is a multifaceted issue that includes the inability to access safe and secure housing, but also includes factors such as unsafe neighborhoods, poverty, and exposure to environmental risks. And so we measured housing insecurity using a multi-level, multi-dimensional housing insecurity scale based on 17 items related to housing insecurity. And in addition to the biological factors that cause diarrheal infections, we also wanted to examine the social determinants of health. And gender is an association that has had limited studies on the association between diarrheal infections and housing insecurity thus far. So we developed 4 related hypotheses to examine this relationship. First, we hypothesized that housing insecurity is more likely to be higher in female-headed households than in male-headed households, that housing insecurity will increase diarrheal infections in Kenyan informal settlements. And we expected that the association between diarrhea and housing insecurity will be greater in female-headed households than in male-headed households. And lastly, that water insecurity will play a significant role in shaping how the association between housing insecurity and diarrheal infections. Sorry. Perfect. So to undergo this research, data were collected from 3 informal settlements in the Nyanza province of Kenya. And in each of these settlements, it was found that over 50% of the residents were experiencing housing insecurity. And then, so to test our first hypothesis, we completed a t-test to determine housing insecurity by participant gender. And we saw that both females and female-headed households, while they experienced higher rates of housing insecurity, the relationship was not statistically significant. Next, we completed a bivariate analysis using Pearson chi-square test and generalized linear regression to look for these significant relationships. And it was found that the main predictor variable, housing insecurity, was significant when regressed on diarrhea, in addition to water insecurity and these other variables shown on the screen. So next, we created a multivariate model. And so we took the statistically significant bivariate variables and we examined them in their association between housing insecurity and diarrheal infections. And in this association, we found that housing insecurity, water insecurity, 5 or more people per house, 3 or more children under 5, and tiled house flooring increased the likelihood of experiencing diarrhea, whereas semi-detached housing and cement housing exterior decreased the odds of experiencing diarrhea. Now, having 5 or more people per house and 3 more children under 5 is particularly important to note because diarrhea is currently the 2nd leading cause of death in children under 5. And so regarding policy, particular attention must be paid to large families with children under 5. Additionally, we saw that housing insecurity and water insecurity had similar adjusted odds ratios. And so we ran a interaction effect between housing and water insecurity on diarrhea. And so the interaction effect between housing insecurity and water insecurity on diarrhea was not significant. However, independently, they did have a significant effect on diarrheal illnesses, with housing insecurity being stronger than water insecurity. And then lastly, we ran a differential effect on housing insecurity by gender, both participant and by household gender. And we found that in both participant and household gender, males were more likely to experience diarrhea, with the association being statistically significant for male-headed households. Thus, the effect of housing insecurity on diarrheal infection was stronger and statistically significant in male-headed households in slums and informal settlements of Kenya. Programs and policies should be shifted to address the rates of diarrheal infections in male-headed households. And third, emphasis must be placed on developing housing and water infrastructure at the same time to address diarrheal infections effectively. Awesome. And so regarding next steps for this project, we are currently in the process of editing it and submitting it to be published. And I'm also working on another paper with Dr. Boateng on housing insecurity and mental health. And then personally, I am also starting a master's degree in global health and McMaster in 2 weeks. I'm very excited. I'm going to complete a thesis. And this upcoming year, I'm also going to be a youth ambassador for Plan International for their Girls Belong Here program. And then I intend to pursue future doctoral work in the field of global health.
Thanks.
Awesome.
Okay.
I'd just like to acknowledge the Dahdaleh Institute, Canadian Institutes of Health Research, and the Global Environmental Lab for all their resources, and a special thank you to my supervisor, Dr. Boateng, for invaluable guidance and leadership this summer. Thank you.
Thank you. That's great, Mirianna. Don't forget your cheat sheet. Thanks so much, Mirianna. That was great. And our final presenter this morning is Richard Wu. And Richard, you want to come up? And Richard is also working with Professor Godfred Boateng. And together they're examining energy and housing insecurity, the relationship between energy and housing insecurity on health outcomes. And the title of Richard's presentation today is the effect of housing and energy insecurity on psychosocial health outcomes amongst those living in urban informal settlements in Ghana. Over to you, Richard.
Thanks so much for the wonderful introduction, Dr. Urbanski, and thank you to the Institute and to all of the organizers for putting this together and for the opportunity to speak. Hopefully that really long title will make a little bit more sense in a little bit. Yeah, my name is Richard. I'm a research assistant with the Global and Environmental Health Lab, led by Dr. Godfred Boateng, and I'm excited to be able to give a brief talk about some of my experiences this summer at the Institute. So my primary focus this summer was looking into the effect of housing and energy insecurity on the risk of clinical depression and anxiety amongst those living in informal settlements in Ghana. By the time I entered the project, the primary data collection in Ghana had already occurred, but there were three major research activities that I conducted with the Institute. So firstly, was a pretty big literature review to establish the fact that there was indeed a literature gap, which I'll talk about later. I helped to develop a research question, conceptual framework, and an analytical plan for what we were going to do with the data. And finally, it was the quantitative analysis of survey data using statistical software. In short, one of my biggest learning objectives for this summer was actually to gain more quantitative statistical analysis skills. And STATA certainly gave me a run for my money. So I'm really happy about that. And being able to sort of parse out exactly what the most important parts of the data are and present it in a meaningful way was also something that was challenging. And I hope that the rest of this presentation goes well as well. Yeah, so but with respect to the project itself, To give you a little bit of context, despite the enormous disease burden of mental illness worldwide, and especially in low to middle income countries, I was actually really surprised to learn during the literature review phase that there were very few, if any, published pieces of literature looking into specifically mental health effects and the interaction between housing and energy insecurity in Ghana or even sub-Saharan Africa. Using two recently validated measures of housing and energy insecurity, so the multi-level, multi-dimensional housing insecurity scale and the household energy poverty experiences scale, we had two objectives. First was to determine whether there was indeed an association between housing insecurity, energy insecurity, and poor psychosocial health outcomes. And then to discern specifically which elements of these insecurities contribute to poor mental health among those living in slums and informal settlements in Ghana. Also wanted to note as well that the psychosocial measures, specifically depression and moderate to severe anxiety, were actually based off of two other scales, the WHO well-being scale, a 5-point scale, and also the 7-point generalized anxiety disorder scale as well. So for the sake of time, there are actually 4 graphs, but I'm going to try and summarize them really quickly here. On the right side, you'll see results of corresponding to the first goal. So you'll see that there is a crude odds ratio, and as well as a t-test looking at if you had what the difference in housing insecurity score would be for somebody with clinical depression and for somebody without. So in both cases, this was pretty statistically significant, with a crude odds ratio of somebody with housing insecurity also experiencing clinical depression. And then on the left side there in the big graph where the dotted line is 1, so a null effect, anything to the left and tending towards 0 was can be considered as sort of protective and decrease the incidence, or was associated with a decrease in incidence of clinical depression, whereas anything tending towards infinity or after 1 was aggravating. So in this case, looking at housing insecurity and predictors of clinical depression, it turns out that housing type, living within a semi-detached residence, seemed to aggravate, or at least was associated with an increase in the prevalence of clinical depression. And then similarly, if we go into similarly looking at housing insecurity and predictors of, let's just say, anxiety. Housing was also one of the major contributors. However, we also found that female respondents, or female identifying respondents, were also much more likely to experience moderate to severe anxiety. So if we go to the end here, I kind of took all those 4 graphs and tried to summarize them. In short, there were fairly significant associations between housing and energy insecurity and clinical depression and anxiety. And poor mental health outcomes were also associated with housing and energy insecurity, were also found to be heavily influenced by socioeconomic factors. With respect to the risk of clinical depression, socioeconomic status and living in close proximity to others, and as well as religion, seem to mediate the risk of clinical depression, whereas female identifying respondents experiencing either form of insecurity were a significant risk of moderate to severe anxiety. In terms of policy considerations, one of the mediators that I highlighted was it seemed to be housing type, and so this could point to potentially looking at improving housing, but not in a way in which you just improve the structure itself, but looking at ways to encourage community building, because, as I said, living in close proximity to others seemed to really buffer or be protective of mental health. What's next? We're looking at potentially analyzing the association between these 2 types of insecurity as well as stress. The reason why stress was not necessarily included this time around was because stress, there's actually no clinical cutoff for what is considered to be high stress or low stress. And so it's a very different type of analysis. And we're also hoping to write up an abstract, publish a manuscript, present at conferences as well. Yeah, thank you so much for your time, and thank you so much to my lab mates and Dr. Boateng for keeping me together, and thank you so much to the Institute for providing me with this wonderful opportunity. Thank you.
That's great. Thank you. Why don't you stay up here, sure, because I'm going to ask you some questions. It was a great presentation. And just before I ask Richard for some thoughts and comments, just remind people, you can ask questions, just raise your hand if you're in the room. If you're online, excuse me, please use the chat function, or just raise your hand on the digital bar down below, and we'll do our best through Hannah to make sure that we get your question asked. So Richard, that was a great presentation. There were so many thoughts going through my mind, but there's two things that I want to ask you. And I want you to sort of reflect a little bit on Mirianna's presentation, where one of the key findings was that male-headed households have a higher incidence, or male-headed households have a higher incidence of diarrheal disease. And yet in your study, the research that you found, or that you've been engaged in, you found that women, particularly in a lower socioeconomic status, who are experiencing housing and energy insecurity, have a higher incidence of clinical depression and anxiety than men. So can you just kind of take those two findings, one you found and one Mirianna's found, and just maybe think about what that might mean?
I think that's an incredible question. I think in the absence of like data, I think one of the biggest components, and this is something that I intend to kind of dig into sociologically, but I have a feeling that there is a cultural component as well. One of the findings, one of the notes that actually Dr. Boateng provided me with in trying to explain why women tended to have higher, women were also associated with higher rates of clinical depression, was just the high rate of, unfortunately, gender-based violence in Ghana. And so I think, without trying to make too many conjectures, I think one of the possible avenues to look down would definitely be what components of culture would sort of explain both of those findings together. I think that both of these findings are not necessarily at odds with each other. I think that there are actually, in my mind, quite a few explanations that could possibly explain them both and are congruent with each other. But I don't necessarily want to just kind of go out on a limb without really doing the research myself, if that makes sense.
It does, yeah. And I would also ask you, you said that you'll be obviously doing some writing and then seeking to publish and so on. What are the policy implications of your findings, and how would you formulate those for, I don't know, for a minister of health or a minister of urban planning who you meet at an elevator and he says, "Oh, I heard about the study you did. We've got 20 seconds. What should I think about?"
I think one of the findings that I found throughout the literature was this emphasis, even in studies looking at a similar question that's not in sub-Saharan Africa or in Ghana, there just kept being this theme of mental health being a very low priority, unfortunately, in a lot of health policy. And I think what this study and these results point to is the fact that mental health matters, and mental health, in conjunction with all of these things that we know about socioeconomic status, with living conditions in general, they can sort of compound to produce negative health effects. And so I'm so sorry. I literally just lost track of your question.
Well, I'm asking around.
Yeah.
What are the policy implications
Right.
of your plan?
So I think in addition to increasing supports and services on a system scale for mental health services, I think that poverty reduction should be a priority, especially because if we look at some of the odds ratios in sort of every graph, you could theoretically attribute poverty to every single one of those significant findings. In addition to that, again, there is just another emphasis on the fact that we need to do more female-oriented supports. And then also, as I said before, also looking at how do we develop communities that encourage community building rather than just improving the substance of the infrastructure. So, having additional semi-detached housing might be better in terms of physical infrastructure, but what the data that we have found shows is that community building and making sure that we're living in harmony with one another and in close proximity and feeling that we're part of something bigger is very important in terms of mental health outcomes.
So I'm glad you raised that, because one of the things that I saw in your presentation was a certain kind of incongruity between semi-detached housing, which to me would imply that you're actually living quite close to other people, right? So you've got just a little wall between you and your neighbor, and then another little wall between you and your neighbor over here. So your proximity is actually quite high. So you said that reduced or that increased your risk of clinical depression, and yet you also said, or you found, I'm not accusing, I'm just asking for an explanation of your description. You also said that living in close proximity is a protectant, right? So there's an incongruity there that I think the kind of explanation that you've started to explore, I think is really, really important. Do you want to just maybe offer some thoughts on that?
So that specific question asked respondents to indicate whether they lived in a semi-detached house, whether they lived in a unit or a room within a compound house. So it's kind of like a semi-detached except with like 4, 5, 6 units. And then whether they lived in a kiosk, and specifically in a kiosk with other kiosks around it. And then there was also another one that was other, but there were very few responses and it wasn't statistically significant. So in the context of those 3 answers, the semi-detached housing was the most isolated, whereas
that's very interesting.
It was definitely the most isolated, and you can sort of inference that there were the fewest possibilities for human interaction or community interaction. And so I should have, that's actually a really good point to highlight for next time. And so that's sort of where the basis comes from.
Well, Richard, thank you. It was a great presentation. Very clearly, you've learned an enormous amount in terms of research skills, in terms of how to think and how to approach highly complex problems. And you're actually really good when people put you on the spot. You did really well. So thank you so much.
I'm always sweating a little.
Thank you. Well, that's okay. You did great. That's fantastic. So I'd like to just ask Sepinoud to come up. I apologize for my pronunciation of your name. Oh, you're online. There you are. Have I got your name right, Sepinoud?
Yeah, you're saying it perfect. Yeah.
Oh, well, that's great. Well, then I retract my apology. So, Sepinoud, you talked or you described your effort to engage in a descriptive research documentation process around changes in Canadian public health legislation in the context of COVID. And one of the things that really struck me about your presentation that might be interesting, and I'd love to get your thoughts on this, was that there were multiple differences in strategy across provinces and territories. At the same time, the federal government had its own strategy, right? Which wasn't necessarily independent of the provincial strategy, or of provincial and territorial strategies. And the federal government's approach was one that did not rely on the Emergency Measures Act, but that relied on existing public health institutions and legislation at a federal level, but at the same time expected provincial adaptation to emergency conditions. Do you have any thoughts on that?
So yeah, that's a good point, because when you look at the defining piece of federal public health legislation being the Public Health Agency of Canada Act, that hadn't changed in many years. Even with the onset of the pandemic, it hadn't been reformed or changed. And I think you can attribute that probably because they were enacting the Emergencies Act and relying on that as a way of, exercising their public health powers. And so they didn't really need to reform the Public Health Agency of Canada Act to respond or better respond if it was insufficient before. So I think an interesting aspect of this research is probably looking at provincial emergency management legislation as well and seeing how that had changed, because a number of provinces, although they rely on the Public Health Act that have to kind of guide how they respond to public health emergencies, they didn't shy away from also enacting their Emergencies Management Act to kind of give the provinces more broader power to deal with outbreaks, either to deal with people not complying, just give more powers to the provinces. And so it would be interesting to definitely look at those pieces of legislation and see how, if they acted together or in contrast, because one of the frustrations with the research was that you wouldn't find changes where you expected to find changes. And so maybe those changes can be found in emergency management acts instead of the public health legislation acts. So that is something that I think would be interesting to incorporate in the next phase of analysis, probably.
Yeah, and I would just point out that the federal government did not use the Emergency Measures Act, right? It actually, there was a very deep and careful consideration of whether or not it should or should not use the Emergency Measures Act because of COVID, and it did not. But each of the provinces and territories, many of them invoked their own provincial emergency measures by legislation. Right? So that might, I guess what I'm kind of getting at is that without a coherent federal government Emergency Powers Act in the face of a pandemic, that may actually be an important driver of, let's just call it incoherent, maybe that's too strong of a word, but inconsistent policy practices across provinces. And it seemed to me when I was listening to you talk, that's kind of where you were going, at least with the analysis that you were finding. Does that make sense to you?
Yeah.
The other thing I just wanted to ask you was, you said that you were looking for changes in legislation, did you, as opposed to changes in practice, right? So legislation, do we always need to change legislation in order to change practice, right? Or does certain legislation under certain conditions, does it allow for flexibility in practice? Is that a question that comes to mind for you?
Yeah, I think that's a good point as well, because, at the Public Health Institutions research program, we're very focused on public health institutional design and governance. It kind of seemed like, the logical next step to look at public health legislation to kind of defer where authority was coming from, either to the, chief medical health officer's role, or the basic functions that, the public health agencies are supposed to serve. And so we looked at that as kind of defining for us what they can and cannot do in terms of their scope, their jurisdiction, and the authority that they have. Because it's something that the lab had explored in the past, like before the pandemic, specifically with regards to the Chief Medical Officer of Canada. And so we wanted to see if that had shifted, given, the many considerations that the provinces and territories had to consider with the onset of the pandemic. And so I think in practice, for us, it seemed like a lot of it was being derived from legislation. And interestingly, like in Alberta, there was a Public Health Act review committee. And we saw that a lot of the recommendations of those committees kind of sparked by public not backlash, but public commentary on what the Public Health Act should be able to do and shouldn't be able to do. A lot of the recommendations from those committees were then directly implemented into the Alberta Public Health Act and kind of adopted. And so I'd say in practice, the provinces and territories definitely had to be open-minded, especially when they were invoking their emergency powers under the Public Health Act, because it can sometimes be so expansive. And so I think a lot of the changes and like the dynamics were in response to trying to limit their own powers, recognizing that this is like an exceptional circumstance and that the use of emergency powers may not be so politically favorable. So I think in practice, a lot of that, affected legislation as well, which we see in the Public Health Act reforms.
Yeah, it would be interesting as well I know that after SARS in 2003, there were major reforms to the Public Health Agency of Canada. There were also major reforms, legislative reforms in relationship to the Medical Officer of Canada. And their authority and their independence from political bodies was significantly altered after SARS. So it might be interesting at some level, in your future work, to try to do some sort of a comparative analysis on lessons learned, if you will, post-SARS versus post-COVID at a provincial, federal, around provincial, federal interaction and legislative authority. But I just want to thank you, Sepinoud, for a great presentation. It's extremely thought-provoking. And you obviously have learned a great deal. And I just wish you the very best for your future. So thank you. So Shamim, why don't you come on up, and I'm going to ask you a couple of questions as well. And I will just again invite people in the audience to ask questions if they would like to. Shamim, your presentation, just to remind people, focused on Global Wellness and Input Lab, a new initiative, and obviously having some fantastic outcomes and impacts. What have you personally learned the most? What's the biggest learning for you personally over the time that you've been an intern with the lab?
Well, definitely like my experience over the past 4 months hasn't been like the other interns. I've been trying to kind of create into a reality what Harvey and Susan's vision was. So I've definitely learned a lot about just communication with not just peers, but with supervisors, and what teamwork can accomplish when you communicate together. And I've seen kind of like trials and errors of what can go wrong when you communicate poorly with one another. So that's like a huge learning lesson that I had, especially when it came to what it was exactly that we wanted this lab to be, who it was that we wanted to impact, and how we can do that. Mm-hmm. So over the past 4 months, in the first month, we started off with kind of understanding who we are, and as a team collectively meeting and brainstorming different aspects of those questions that I was asking. And then as well, after the first month where we kind of established, okay, so this is our core values and this is our passions and this is our vision, how are we actually going to implement this? So it wasn't something that like Harvey or Susan could have handed me like a piece of paper or like really necessarily given me a to-do list. Like it had a lot more of skills such as creativity and initiative taking that I had to kind of do. And through that, I saw a lot of things with such as the idea to create a climate cafe, because we've learned that climate action projects can either have very successful outcomes or they can have very controversial outcomes. So this was something that at first was like, okay, I definitely want to think of the best creative way to conquer this. We looked at different organizations that had been working on stuff that's similar to this. We actually found one that's called Carbon Conversations Toronto. So they also host climate cafes, which is on more of a regular basis. And we learned that this engagement and through these events, that people can come in, and although some people may not necessarily resonate with our structure and agenda, it can be something that they can still have a takeaway. Like one of our participants, her takeaway was that she wanted to have a meatless week because she learned that not consuming meat can actually reduce carbon emissions. Another participant was saying that I don't want to necessarily focus on feelings, I want to focus on action. So a lot of people had different takeaways from this, and that's another thing that I learned, that even if you have a true demographic for your projects, even if you have a true research question or just quest for what you're trying to achieve, it's not always going to resonate with people possibly how you want to. But it's the fact that you took that initiative and you really tried your best to ignite that spark within people, for them to see your passions and see what you stand for. And it's honestly been a really great journey, like doing that over the past 4 months. It taught me more about how to stand and be resilient.
That's great. That's one of what you've just described is one of my learnings over many years. It took me a lot longer to learn it than you did, about leadership, right? That it's leadership is really about creating spaces where a variety of people and a variety of perspectives can find comfort and support, right, for their initiative, for their creativity. And you know, you're just listening to your presentation, watching how you engage people. I just think you're going to be a great leader. Thank you for your presentation. And I hope you continue with Harvey and Susan.
Yeah, I'm actually going to, for the fall and winter term this year, be at the DI.
Oh, fantastic. Well, that's great. That's great. Well, thank you so much.
Thank you so much.
And Mirianna, where are you? There you go. Come on up here. Yeah, it's also Mirianna was also, if you remember, she was working with Professor Dr. Boateng, and I have many questions, but the one that I think is probably the most important, at least initially, is what in your description, what is housing insecurity? What does that mean operationally? Does that mean no house? Does it mean sometimes a house? Does it mean different types of houses? Different types of access to different services? Like what specifically is the operational definition of housing insecurity? That I think was a question that kept coming to mind.
Yeah, of course. So housing insecurity, we define it as I said, a multifaceted issue.
Come close to the microphone if you don't mind.
We define as a multifaceted issue that involves the lack of access to housing that is safe. And so in the scale that we use to measure housing insecurity, there are questions related to access to electricity, toilet access, sewerage access, and then also relationships with their landlord, so the ability to pay rents, stresses from the landlord, if they experience mold or sludge in their housing, so questions related to that. So it's really related to the built environment, essential utilities, and landlord and tenancy situations.
Okay.
Yeah.
And so I guess the outcome that the ultimate measure would be an experience of the person, of a sense of insecurity, that this is precarious and that it's not something I can count on. Is that very accurate?
I would say yes, in a sense, because we measured it on a scale. And so the items that we used to create that scale, there were 17 questions related to the questions that I previously spoke about. And the more, if they answered yes to those questions, the higher they scored on that scale. And so that's how we define housing insecurity.
Okay, that's great. And then I'm sure you're expecting this question. Why do you think male-headed households have a higher incidence of diarrhea?
So we came up with as I was thinking about this was a surprising finding, as it did reject the hypothesis that I originally put forward. So some reasons that we came up with is that women are primarily responsible for water collection, sanitation practices, and also childcare, taking care of children, and also healthcare seeking practices. And so they are able to do those things. They know what to do in those situations, and they're educated about how to take care of children, how to decrease points of contamination, and things like that. Additionally, in male-headed households, women experience lower levels of autonomy within their households. And that's particularly important regarding resource allocation. So in female-headed households, they'll be able to allocate resources to sanitation practices, water, and things like that reduce the likelihood of diarrheal infection.
So for me then, when I listen to that explanation, that assumes that male-headed households and female-headed households have equal access to resources. And that's not necessarily true. In fact, most female-headed households are in a much more precarious situation. And therefore the finding that male-headed households have higher incidence of diarrhea, I think it's a very, very interesting finding. I see that Gottfried is online, and I won't invite him to comment on it, but I think that's a really, really important question, and really trying to tease that out and being very specific about operational definitions of what specifically is a male-headed household. Does that mean no women in the house, or does it mean predominantly male-headed, or predominantly the power structure of the household is the man is at the top, versus a woman's headed household? Does that mean no man is in the house, or that the woman is at the top of the power structure within the household? Right? So those are different. Those are different conceptions of what those terms might mean. But I think it would be really interesting to explore those further. And the other thing that I really was interested in listening to you was you didn't talk a lot about sanitation. You talked a lot about water and water insecurity. But does your concept of water insecurity, does that include sanitation, or does it exclude it, or did you exclude sanitation for a particular reason?
So sanitation was included in the water insecurity part. Wash services, water insecurity included access to being able to access clean water, and just being able to decrease points of contamination between food and water that's consumed.
That's great. That's great, Mirianna. Thank you. Well, thank you so much. And so you can have a seat. Yeah. Thank you. Yeah, well, we are really close to concluding here. I would like to just first of all thank each of our presenters today. Each of you did a wonderful job, and were very inspiring examples of the kind of learning that we really try to encourage at the Institute. And I think in addition to all the descriptors that we've used previously at the beginning of this symposium, one of the things that I've really tried to emphasize, and that our team tries to emphasize at the Institute, our executive council and our staff team, is actually creating a culture of support where students especially, and also grad students, but undergrads very particularly, can have an experience of research where they actually learn very practical skills, but where they also build their confidence and their confidence in themselves and in their own minds, in their own abilities. And I think what strikes me more than anything today, I mean, I've asked every one of you a question, a very specific question, and they weren't easy questions. And every single one of you had incredible poise, incredible confidence, and an incredible ability to actually respond to the question in a very meaningful way. And I think that is a fantastic marker of what your learning experience has been. And for me, as a professor, we as professors, we want people to learn. That's our number one objective. And we want people to fall in love with what they are learning, right? And to be clear-minded and to be rigorous in how they approach that. And I am just, as a professor, I'm just delighted to see where you guys have the journey that you've been on as interns and where you started versus where you are now. And what's very clear for each of you, you have a wonderful future ahead of you. You have very clear questions, you have poise, you have confidence, you have the ability to work very well with others in transdisciplinary teams. I can't imagine a better outcome for the mission, if you will, of a university. This is exactly why we exist, is to do good research and also to teach people how to be good thinkers and to make meaningful contributions to society. And I'm just delighted to see the results. I would also just take this moment. There's one thing that really struck me, Mirianna, that really struck me. Shamim actually said it, and I'm going to actually use it on our website. I thought it was fantastic. She said the DI is about initiative and recognizing that creativity is your greatest asset. And I cannot think of a better summary of the kind of culture that we want to create. And with your permission, Shamim, I'd like to use that and put it on our website. So yeah, thank you. Yeah. And then with that, I will say that none of this happens, without a lot of people. And your professors, as you have each acknowledged, the graduate fellows, the postdoc fellows that each of you, and for those who've been in association with them, you have acknowledged. These are people who really care about teaching and research. And they're here at this university because they care and because they want to actually impart knowledge and research. So I'd like to thank each of the faculty that have been associated with the Global Health interns, also the postdoc fellows and the graduate students that have interacted with the Global Health interns over the course of the year. But I think with that said, the staff of the Dahdaleh Institute are truly outstanding. And Hannah is here today in person as our events coordinator. And there's a lot of detail that goes into making something happen. It's just like research, it's not magic, it's hard work. And there's detail. And Hannah is fantastic. She has great attention to detail. So thank you, Hannah. And then we have one of our other staff members is Fernando Rua, who's our finance person, and that's an even more kind of distant, if you will, from the public nature of what we're doing here, but it's absolutely fundamental to the functioning of the institute. He does a great job on not just finance, but on so many other things, supporting so many other elements of administration. So thank you, Fernando, for your support. But most importantly, and not with any diminishment of Hannah or Fernando, most importantly is Teresa. Teresa is the coordinator of the Institute. And each of the interns know Teresa very well. Because Teresa, not only does she coordinate all of the activities of the Institute, but student support is one of her primary goals, one of her primary professional objectives. She really takes it seriously. And whether that's undergrads, grad students, postdocs, community fellows, doesn't matter. She takes it very seriously. And she really runs this program, the Global Health Intern Program, identifying opportunities, matching students with faculty, managing all the finances, managing the payments, and managing the various administrative aspects, and then also just being available when people are confused or scared, or they don't really know what to do, and they don't really know how to begin. Teresa is always available and has done for the 5th year in a row just an absolutely stellar job. So Teresa, I know you're online there somewhere. Thank you so much. And with that, I think we can very happily close this 5th Global Health Intern Symposium. And again, thank you to each of our presenters and to our guests who come to see your work. Thank you.